Thank you. Good morning, everyone. I'm sorry I cannot say hello in Greek, so I'm going to present in English. Thank you for the organizer to put the epidemiology of CP in front with this first presentation. So the title is Complex, Why Cerebral Palsy Remains the most common motor disability in childhood to date. And I would like to introduce some points that can explain how epidemiology can try to put forward the prevention of cerebral palsy. So when I first think of this presentation, I wondered what does everyone knows about the epidemiology of cerebral palsy? And I think there are three main points. The first is a general sentence that we already all know, which is cerebral palsy is the most common motor disability in childhood. So it is in the title of the presentation that was suggested by the organizer. It is also all publication that you can read in the introduction section. So I think this is something that we all know. The second point is that we have a rough idea of how common cerebral palsy is. And the main figures that come in mind are 2 to 3 children per 1,000 live births. Again, this is something that is repeatedly described in publications. And probably the third point is that we have some evidence that CP has declined, at least in some part of the world or among certain subgroups. And what I propose is go a little bit with further details into these 3 points. So when we think at epidemiology, we have to count the number of people affected by the disease. So it is really important to understand the condition and its impact. And so we have to base our thinking about accurate counting of CP prevalence because it has, as you can see, several implications. So the first probably is public health strategies. And when we think at public health strategies, we think at prevention. We also think at early interventions to be put forward. So these two topics are particularly important in high-risk populations. Epidemiology of cerebral palsy also guides resource allocations to be sure that each child affected access to the resource it needs. This is also important to enhance our understanding of risk factors and etiology, and it is also used to assess the impact of advance in medical care, especially in obstetric wards and in neonatology, but all people in this room, I suppose, have something to know with advance in improved care. And at least we have to think that the knowledge about epidemiology in terms of numbers, the knowledge of, epidemiology of CP, can improve outcomes for the affected children, their families, and the communities where they live. So when we say a count, we have to have an indicator, and the main indicator is prevalence. But you can see in the publication that there are many ways to report prevalence, because according to calculations, the prevalence estimates reflect different realities and must be interpreted differently. So the first and the most common way to report CP is using what we call birth prevalence. It focuses on children with CP born in a surveillance area a given year, And this number is compared with the total population of children born alive the same year in the same area, and it is reported using per 1,000 live births, and sometimes per 1,000 neonatal survivors. And I will go back to that point a little bit later. So this is the most famous way and use of prevalence in the field of CP, but we also have the possibility to calculate what we call a point or period prevalence, which focuses on children with CP of a given age, but who reside in the surveillance area at a specific period of time. And this number, again, is compared with a comparable population with and without CP, so the total population in the same area with the same age and on the same period. And these prevalence rates are expressed using per 1,000 residents or per 1,000 children of a given age. And the slide here compares the use of these two means of calculating prevalence and what we are looking through the lens of birth prevalence or period prevalence. So when we use birth prevalence, we measure the risk for developing CP in a longitudinal approach. It's like we follow up a cohort of children born in the area, and we follow up them until they develop CP. So it's mainly for research purposes, so etiology, risk factors, but also to measure the long-term outcome measures of perinatal care. In other conditions, it is named incidence. The second way of looking at rates is a point or period prevalence, and it measures the burden of the condition in the community. So it's a cross-sectional approach, and really it focuses on public health issues, so priority settings in public health, in social and health needs, and for service planning purposes. So you can see that there are two different options and two different ways of calculating prevalence, but interpreting also the results. So if we think at prevalence, we speak about populations. And because CP has a multifactorial etiology, we have to think very precisely at the population we are surveyed. So prevalence must be interpreted according to the population being studied and its risk level. So probably the first distinction is to consider is the timing of the brain injury, shifting two groups into two groups, the pre, peri, or neonatal injuries, and in the second group, the post-neonatal injuries. So when you see a number or a figure of cerebral palsy, it is important to identify whether post-neonatally acquired CP are considered in the calculation, even if I must recognize that in high-income countries, this number does not affect a lot the prevalence estimate because it's rare, but in low and middle countries, it's not the same thing because the condition, the post-neonatal CP are more frequent, so it is important to know. But even if it is rare in high-income countries, it is important to know whether they are included in the calculation because the context of prevention of developing CP and of prevention is not at all the same. And the second point that is most important is premature birth or lower birth weight. And when we look at this subpopulation of children with CP, those born preterm, we have a very heterogeneous group in terms of risk, with a risk, as you know, which increases with higher immaturity at birth. And this increase can be as high as 60 to 130 times more likely to have CP compared to full-term children when children were born extremely preterm. That means below 28 weeks of gestation. The risk, of course, is less in more severely premature babies. One thing that we have to keep in mind when we think at prevention is that premature births continue to be prevalent in modern obstetric practices, despite the advance in medical care. And we also have figures showing that children born preterm represent a significant proportion of children with CP, not the majority, because even if those born at term have a much lower risk for developing CP, they are more numerous, so they represent the majority of children with CP in a population. Last thing, when we want to interpret prevalence estimate, we have to consider the methodology used for data collection. And you know that the gold standard is methodology based on population-based registries or surveillance programs. But in the literature, we have more attention focused on administrative data, which will be in the future a very large source of data for epidemiology. But for now, these databases have some limitation, especially in the performance for identifying CP, and there are some studies reporting under and biased reporting of CP in these databases. The second, and I already talked a little bit about that, is population characteristics. And so we have demographic variations with geographic and socioeconomic factors to be considered. We already spoke about risk factors such as gestational age or birth weight. We also have to know the survival rates of extremely preterm babies and probably also the survival rates of individuals severely affected with CP. And we have to know the context in which they were born, especially obstetric and neonatal advance. Then we have to know about the definition used for the survey, the definition of CP. So because the diagnosis is based on phenomenology, we exclude other conditions, and this may vary according to surveys, and also the large variability in the clinical presentation can lead to some discrepancies in reporting rates. And finally, we have also to consider the time frame of data collection and generation considered. So now we move for rates and numbers. So the first point is to know that the prevalence of CP varies across regions and populations. We have a very big survey led by the Global Burden of Disease Study that estimated that 1.2% of children under 5 have CP globally. And we know from this survey that a significant majority reside in low and middle income countries, the African region being the most prevalent region. We also have a very important study from McIntyre in 2022 that gave us the current prevalence estimate. It was a very large study involving 41 regions and 27 countries, and the global CP prevalence is reported as 1.6 per 1,000 live births in high-income countries, and more than double in low and middle-income countries. We also have a significant heterogeneity of prevalence in China, and you can see the numbers from 1 to nearly 7 per thousand children aged under 18. In Europe, the latest prevalence estimate was published by Cellier, and it is 1.8 per 1,000 live births. If we now look at this population, very vulnerable, the children born preterm, we know that they had a higher risk of CP compared to children born at term. And to interpret the results, we have to keep in mind that the morbidity, the neonatal morbidity they have is extremely important to consider when we look at the risk for CP in this population. And there is a very interesting study conducted by Chen who explain that for the same gestational age, preterm children who develop neonatal mortality, such as asphyxia or respiratory diseases, infections, or neurological disease, are particularly at risk of developing CP, which is not a surprise, but maybe the higher risk has to be quantified, and this study proposed this, and the hazard ratio, which is the risk, is 30 times higher compared to those of the same gestational age at birth who did not develop such neonatal morbidity. And for the more extreme premature babies, the increased risk of CP is almost entirely explained by this mortality, neonatal mortality. Of course, the proportion decreases with the others. So it is important to consider adverse consequences of prenatal birth when we interpret the result. So here are the figures for Europe based on population-based registry. We have here the prevalence according to gestational age at birth, and we can see that there is a very high prevalence for those born below 32. And in this group, and especially in those born extremely preterm, half of them have presented with severe phenotype. If we now look at the pooled prevalence of CP in very preterm or very low birth weight infants based on cohort studies, there was a meta-analysis published recently, and the number is 6.8%. In children born extremely preterm, it has been suggested to report the prevalence expressed by 1,000 neonatal survivors, because survival rates still highly vary in this population between countries, and it has to be taken into consideration, especially when we want to compare studies and regions. If we now look at trends in prevalence, we also have notable variations across populations and time periods. The first point is that we observe a general decline in CP prevalence. Global CP prevalence has decreased markedly, by 25% over a 20 period of years. And this is known from this big survey from the Australian team and data collected in high-income countries. In Europe, we observe also the same decrease over a large period of time, and the annual decline is about 0.7%. This decline is seen particularly among children born preterm or with low birth weight. And you have in this table here the numbers for Europe, where we, in moderate preterm and very preterm, or the corresponding with birth weight, we have over a large period of time a decline in prevalence. We have comparable evolution in Australia and similar results also when we look at cohort surveys. The trends in prevalence, which decline, as I said, remain stable or show increasing trends in some regions or some subgroups. In Europe, we have concern for those born extremely preterm, and as I know previously, they have a high risk, but they have also a steady prevalence. In Denmark, for example, the prevalence of very preterm births, very preterm children with CP, yes, has been increasing since 2001, with a huge annual increase, about 2.8%. And there was also a large study in China which showed that the prevalence of CP has increased continuously until 2020. The fourth point is that trends are not available in many regions because population-based registers are recent, and this is the case in low and middle income countries. So as a synthesis, we can remember that looking at prevalent rates is an ongoing process because our understanding of CP develops and healthcare continue to improve. Second, a better understanding on how advances in clinical care improve public health measures and social and economic change might account for the decreased prevalence in high-income countries, could help address the high prevalence rate that we observed in low and middle countries. Third, the advance in healthcare may have contributed to reducing both the prevalence but also the severity of CP, and I do think that they have to be considered altogether. Four, while the prevalence of CP in preterm infants remain a concern, we have to keep in mind that their survival rate have improved, which has potentially led to an increased detection of CP in this population. And finally, the persistence of high prevalence of CP in certain regions of groups underscores the need for ongoing surveillance and further research to enhance prevention efforts and accelerate the adoption of early intervention strategies. Thank you for your attention.